Trust is a really difficult sort of intangible thing, but to me,
trust is about listening to people, understanding people. Trust is about really building relationships over a long period of time.
For me, trust is mutual, trust is earned, and trust is...
It means investment. And by that, I mean to listen to someone actively and without judgment from a place of humility.
Trust for me really is when you're sure that the person you're dealing with has your best interest at heart. You know with a certainty or sureness that they will look out for you. And
it's an effort that each healthcare professional needs to pay attention to. It's not free.
Listening, active listening.
I think it means transparency. And the reason why
I believe desperately underestimating the value of trust. If we can live with less fear because we trust each other more, I would say it's a top priority.
It seems to me that without trust, we will make no progress. You cannot work with a doctor that you don't trust. You cannot work with scientists you don't trust. So that feels to me, trust is at the absolute core of what we're talking about.
In healthcare, mistrust can be especially damaging, leading to poor health outcomes and worsening inequality. When people distrust in health interventions, they are at higher risk of poor health outcomes, and this type of mistrust is a social determinant of health and a barrier to getting equal healthcare. But there's a challenge. Clinical research often underserves key groups, such as women of reproductive age, people from ethnic minorities, young people, older people, people with complex health needs, people with disabilities. And this can mean that health innovations might not work as well for everyone. And inclusivity in research, it isn't just about fairness or social justice. It's crucial for excellent science. When we fail to include all voices, we miss out on important insights that could improve the health outcomes for everyone.
Nowhere is trust in healthcare more important than in the area of clinical research. Clinical research underpins all advances in healthcare.
Clinical research is a very broad term. And what we're trying to do always when we're thinking about clinical research is to improve care for patients. So that's the ultimate goal.
I think we have a lot of examples on how we can modernize healthcare via clinical research. And this is because it is clinical research that leads to the implementation of new findings within diagnostics, within prevention, within treatment.
Research offers the chance of finding new ways of treating conditions which affect people's lives, impoverish their ability to function, and perhaps reduce their life expectancy.
We can't advance medicine, we can't find new treatments, we can't progress in society without research.
Inclusive research is the most important thing. It's research's biggest challenge when we look at the decade ahead. We've got to be really honest with ourselves and say that, shamefully, we've not really paid enough attention to this. It's a fundamental problem in terms of making sure that the research is genuinely applicable and relevant to all of the communities we serve.
When clinical trials don't include people who represent all of us, it can seriously affect everyone's health.
Heart disease is the #1 killer in the United Kingdom. And although there is a risk of heart disease across all ethnicity and ancestry groups, there's a higher risk for some than for others. Clopidogrel is a medication that's been used for a large number of years, known to be broadly very safe and very effective after someone's had a heart attack to prevent them from having a further heart attack. For clopidogrel to work for people, it needs to be activated in your body.
Unfortunately, common DNA variants in some populations, including British, Bangladeshi and Pakistani groups, prevent the activation of this drug. Emma's study shows nearly 2/3 of people from these backgrounds may not fully benefit from clopidogrel. Yet, clinical trials that informed its use included no participants of South Asian ancestry, highlighting a critical gap in research and treatment. Prescribing medicine to some ethnic groups that offer little or no benefit to them is putting their lives at risk. It is crucial to involve people from Black and Asian minority groups in health research. Otherwise, health innovations and modern healthcare will not be as effective for them. But clinical research has underserved Black and Asian ethnic groups, and they have been far less involved in UK drug and vaccine trials. Historical abuse and breach of ethical and moral codes have played a major role in the mistrust and reluctance of many ethnic groups to engage in medical research.
There were a few things that patients had told me, and there's a few things as a clinician that I've observed over the years that made me realise that actually trust is a massive issue for the patients that I serve. So the vast majority of the patients that I look after, because of the nature of Sickle, are of Black, African and Caribbean descent. The main reasons that they mistrust are more institutional. I think that they have been, in the main, taken advantage of, utilised as a tool, as opposed to being fully involved and engaged in research. There's quite a few historical reasons why, but the two that jump to mind from a historical perspective are the Tuskegee study and the Henrietta Lacks case.
The Tuskegee study was a trial conducted in the 1930s in Alabama, where Black men were deliberately recruited based on their skin colour and deprivation. They were used as guinea pigs to observe the effects of untreated syphilis. At the time, we knew of a safe and effective cure, penicillin, but it was deliberately withheld from them. The consequences were devastating, not only to their health, but also to their families and future generations. The last survivor of this atrocity passed away in 2004. This is not just history, it continues to shape our present.
This study was a clear breach of ethical and moral codes in relation to research. Henrietta Lacks was a Black woman with cervical cancer in Baltimore in the 50s, and unfortunately her cells were taken without her knowledge and utilised to create the first cell line, so cells that could be used for science that grew outside the human body. The pharmaceutical company that developed this cell line made billions. However, the Lacks family never received anything. It highlights the Black people being taken advantage of.
You know, medicine and science has a long history of, frankly, racism, abuse. Not all of it. Some of the best people in history have been scientists and doctors, but that you can't deny that history.
We need to do things differently. And the Lacks family are a clear example of how they have used that situation to bring good to the world and the scientific community. The issue of mistrust is a global problem, not one that's limited to those of ethnic minorities. Using the example of vaccinations is a very good one. There are a lot of anxieties and a lot of myths and misconceptions in relation to the COVID-19 vaccine in the Black African, Caribbean, and the South Asian population, mainly as a consequence because they weren't taken along in the journey.
When it comes to vaccine hesitancy in different communities, we see there's often a very good reason for it. It was minority ethnic communities that were hesitant around COVID vaccine, and that led to a lot of suffering and death. We see it's very different. It's white middle-class communities that are hesitant around MMR. And that's very complex. It's to do with who perceived themselves to be affected, who consumed the media promoting particular harms, how that information about harms was disseminated, and who trusted what sources. It's really important we don't perpetuate narratives that say certain communities are behaving irrationally or against their interests or in ways that are foolish. You know, there's always, when we look at people avoiding healthcare, there is sense and reason, there is evidence behind them doing it. Medicine and clinical research has a long track record of, yes, achieving amazing things, and we're very, very good at celebrating all that. What we're less good at pointing out is that we have really often failed to engage lots of different groups, and often they're the groups that most need treatment. We have a long history of excluding women, of excluding children. Those are two groups with specific vulnerabilities. And when it comes to ethnicity, poverty, we've really often failed to engage those groups. But the straightforward reason often that they're harder to engage with, but often the people conducting the research don't know those people. We're not part of those communities. I mean, unavoidably, look at me. I am a white, middle-class, straight man, and medicine and science in general are heavily populated by people like me. Unless we have people doing the science and people engaging with the science who are not like me, who are different to me, it's hard to see how some things will ever change. What we know very well from the history of medical research is that when patient groups become involved in research, the whole thing entirely changes.
In North London and across the UK, the NIHR and the NHS are developing clinical research that engages our underserved communities right from the beginning, taking their voices and enabling them to be part of the process. Key to these projects are creating equal partnerships with community organisations and the public. Change is happening.
When we're asking diverse communities, those who are marginalised, to get involved in health and social care research, we're asking those communities to be vulnerable, to be open and honest with us about their experiences, their thoughts, and share their data. In order to make them comfortable and create an open and inclusive space for those individuals, we have to make sure that we build confidence with those people, confidence that we will kind of protect them and look after their interests, whether that's in the information we're using or looking after their care or their health.
I think fear is one of the potential barriers which hold the people for participating in the research. I belong to Punjabi Sikh community. In that particular community, the elderly and the faith are the key points, because elderly people are usually fear about the harmful impacts of the new treatment modality. But once they are explained the holistic benefit of the research and how they are not going to only benefit their own community, but as society as a whole, they are going to participate in the thing.
The main reason the communities are not engaging is because of stigma. They don't understand why it's important for them to be part of the research. You need to use very simple, clear, and honest language, because that way they will engage.
I got a phone call to say, Mr. Hoffman, we found a tear in your retina. And I said, well, what do I have to do? They took me to the clinic. They laser zapped me for about 40 minutes. And it's all clear. And of course, the main thing is that if somebody hadn't done the research on zapping and dealing with tears in retina, I would be blind in one eye.
We should show more positive stories. Our health is important. Longevity of health to myself and to others is very important.
It's relevant to involve the whole community. It's men, women, different ages, different orientations from different parts of the world maybe. So unless we can get the full participation of everybody who lives here, we will not know whether the treatments will work for everybody.
In North London, the NIHR is leading the way with a groundbreaking sickle cell awareness and research event, bringing hope and progress to a community long affected by the condition.
Today is the first NIHR-sponsored Pan-London Sickle Cell event. Now, this is a collaboration between the NIHR and the sickle cell community to try and encourage sickle cell patients to be more actively involved in clinical trials. For such a devastating disorder, there are very limited treatment options, and getting patients more actively involved in the clinical trial process will ensure that we can bring more treatments to market that can benefit sickle cell patients in their wider communities. And then think about what you as an individual would want to change so you can get more actively involved in a clinical trial. We acknowledge the reluctance, the very understandable reluctance that Black people have engaging with clinical trials. Unless patients with sickle cell disease get involved, there won't be any new drugs.
Clinical research has meant to me improved quality of life. It's as simple as that. Like, I've been involved in both drug studies and non-drug studies, and for me the study with voxelotor improved not only my health outcomes but also my social outcomes. Like, before I was quite locked away because I was so tired, I had loads of aches and pains, but after taking voxelotor I then started to, I'd say, thrive a little bit. I'd go out with my friends a lot more, I'd started to travel a little bit more, and I gained the confidence to do that because I was less tired and had a little less aches and pains.
Of recent, I've been involved in the Sickle Eye Project, which is to do with sickle cell patients and their eyes. I think that was one that really touched me in the way that, although I've had my eyes tested and I knew that eye care in sickle cell was important, I never really understood it 100% until I got involved in this study and working together on this study. And it really hit me because it made me realise that, if I woke up tomorrow and lost the vision in one of my eyes, what would I do?
90% of all the genomics research is Caucasian. So we have called that...
With our limited resources, we've got people to listen and pay attention. Transplants were only available to children with sickle cell who had a sibling donor. And we argued, well, if you're an adult, and don't forget, there's only hydroxycarbamide, there's only 2 treatments available to treat you. If those 2 treatments don't work for you, and you're 18 plus, why can't you have a transplant?
I was born with sickle cell diagnosed at the age of 3 and have lived with this chronic illness all my life, battled everything, and then to be of a mature age and then to lose my sight would be devastating. So to me, when I was asked to take part in doing this study, it was a no-brainer.
Pregnant women are often excluded from drug trials for safety reasons, leaving them underserved in clinical research and with fewer effective treatment options during pregnancy and breastfeeding. Maternal health services in the UK have also faced criticism, highlighting the need for investigation and further research to understand the challenges.
At the moment, there's so much scrutiny on maternity services across the UK. A lot of these reports have showed that if you're from a particular ethnic background, for example, Black and Asian women, are more likely to die in childbirth or more likely to experience a poor outcome such as a stillbirth. The insights are really around the fact that we need to do more to listen to women and their families, to show compassion to women and their families so that we can build trust. With pregnancy, it's slightly different to the non-pregnant because you've got the woman and her own risk as she would carry, but you also have the baby or the fetus, as some would say. And there would always be concern in any drug trial as to the impact that any drug would have when it crosses that placental barrier to the baby. A lot of drugs that are licensed for use outside of pregnancy, we know now can be trialed in phase 4 trials for use in pregnancy.
Everything changes when you're pregnant and when you have a baby. Your whole life changes and your whole world and the way you perceive things is completely different to what it was when you were independent and single and without someone attached to you all the time. I had what I would think is a normal pregnancy with my first child, and then he was born prematurely at 32 weeks. There was no reason, well, we didn't think there was a reason as to why he was born early. He spent 4 weeks in neonatal, which was a really, really tough time. I then fell pregnant with my second and I went back to the hospital, but I just felt that I could possibly explore other avenues and get more care and attention. So I came to Chelsea and Westminster and I met with a consultant here to talk about going down a different route. And then they mentioned to me about the research programme and explained that there would be 2 drugs. You're randomised, so you'd either get 1 or 2. I remember when I got the results and I was randomised, it said that I would be on both of them. So it was progesterone and aminophylline. They were always on call, just saying to us, if you've got any issues, you just call us, or if you need any reassurance, we're here. I'd have to fill in a form every appointment, say how I was feeling, like any sort of like side effects, things like that. They'd take it really seriously. And anything you asked or said, any question wasn't silly. They really wanted to hear it and listen to it and answer the questions that you had. I was always worried, my second, my third, that didn't stop. But when you trust someone, the stress is less, the worry is less. I always wanted a big family, but after my first, I didn't even think I'd have a second. And then when I did, the thought of a third became reality rather than it not happening. That's all down to the research, and it was incredible, and I'm forever grateful to them.
When I became pregnant, I was worried about how I would manage the crisis because I'm already having crisis prior to pregnancy. When I was approached to take part in the clinical trial, I was extremely scared. I was very fearful. The first thought was, what's the impact it's going to have on my unborn baby? I didn't want to be a guinea pig, wondering, am I being painted the full picture? Are they giving me all the information that I need to be made aware of with regards to side effects, with regards to the pain, the frequency? I had to do my own research. The trial was about trying to see if blood transfusions, exchange blood transfusions could reduce the impact or the frequency of sickle cell crisis in pregnancy. So the fact that I was seen quite regularly by many professionals across the board to make sure that I was okay and my unborn baby was okay, that I believe was the cherry on top of the cake. It's always very stressful taking time off of work or traveling during the pregnancy to attend these appointments. But then I knew that this was for my baby and for the health and for my health. There's so many questions that need to be answered. And if I can help answer these questions, then why not?
Getting young people involved in medical research is really important, but there are some big challenges we need to overcome to make it happen.
From my own engagement with young people about the definition of research, what you will generally hear is it was inaccessible. People in white coats, labs, test tubes. I think there is a sort of lack of understanding or awareness of what research actually is. But actually, research has a really important role to play in the society we live in.
The Schools Research Network is a collaboration of the NIHR, Imperial College London and Listen to Act, a community organisation. We set up the Schools Research Network with the aim of ultimately improving the health and well-being of young people. We know research is fundamental to that, and we were well aware that we weren't involving enough young people. And in particular, we were very interested in engaging with teachers, and they identified mental health was their number 1, number 2, number 3 priority.
I was aware of the lack of young people's voices in shaping services and in research. If you invest the patience and time and money creating infrastructure for young people to have their say, feel empowered to lead and make change for themselves, the ripple effect can be seriously profound. And I think it's about equipping young people with the skills, the training, the support, whilst also being there as a mentor, as a coach, and listening to them as equal partners in everything that we do. we co-create communities with the young people for young people. And I think it's very empowering.
When I started secondary, the transition was a major thing, but my mum was diagnosed with stage 3 breast cancer just before I'd started secondary. It sort of had a profound effect on my mental health in particular, on how I interacted with my friends and family, on the way I perceived school and other things. I guess the idea of that sort of diagnosis was really challenging because it made other things seem meaningless in comparison. I actually, unfortunately, got into several fights, and that led to me being temporarily suspended from school. But when my mum went to meet one of the head of years, she ended up seeing a poster with like a parental course. And the woman who actually leads that was a brilliant woman. Her name was Shoffa, and she also part-time ran the youth council of Westminster Council. So I ended up joining the youth council. Within a few months, I became youth member of parliament, where I represented 12,500 young people. One of my major manifestos were mental health, another was knife crime, and those were things that were extremely important to me.
I'm not surprised at how amazing young people are. So we wanted to make sure young people were inside rather than outside the tent. That requires an enormous amount of trust to be developed over time. Setting up this mental health research network with the Young People's Advisory Group has been about achieving that trust so that young people are able to meaningfully contribute to research, actually being equal partners in how the research is framed, conducted, and written about and disseminated.
Negative, and it is something that makes you weak. So I've been diagnosed with OCD, and that sort of took a unique sort of toll on me, where you have things like intrusive thoughts and other sort of issues that trouble you, and mine would always link in with like anxiety, and it sort of worked together to sort of create this stressful environment for me, which was really challenging to overcome. But I was able to do it through like support networks and, you know, youth activism, and finding ways to sort of champion my issues and other young people's problems.
Researchers, or even just people within any system, often speak different languages. The language of academia, the language of health, the language of research, and then there's what young people speak, which is often very different. Ultimately, having someone who can bridge that gap, organizations or groups who can bridge the gap between young people and those people working in institutions is really, really important.
Most kids have a real and sincere desire to help other kids in the same situation. And I see that sort of, you only have to very lightly engage with children who are poorly to see they're all raising money. They are, you know, involved in lots of community efforts to make lives better for other people who are affected. And they're big advocates for their condition. So involving children in research just benefits everyone. You know, the clinicians, the kids, and the kids who are not yet affected.
One major challenge for health research is involving people with complex health and social needs. Traditionally, clinical trials were only available in central teaching hospitals, making it hard for those with greater health need in local communities to participate.
And we're sitting here in Richford Gate, where we've established a primary care research facility over these past 5 years. And it's grown pretty rapidly from one study which I was doing in hypertension to now running a large number of clinical trials in commercial and academic areas. We're looking for new therapies which ultimately would come into normal clinical practice.
We are very close to the patient. There is a relationship built already, often based on trust. Our aim as a team is to offer research opportunities to everyone in the community. We are flexible and non-judgmental. The first visit would be testing 5 different tests to see which one can diagnose peripheral arterial disease. The second visit would entail going to a secondary care hospital facility to have a scan, either an MRI or a CT scan. 2 of the patients were identified with a cancer, and this was extremely rare to diagnose both cancers at early stages.
I met Monica 2 years ago when I came for the diabetic trials.
I didn't know much about it, but being it with a diabetic trial, and I'm diabetic myself, I decided it's worth it to go on it to find out more about it.
So in the UK, there are over...
I'm very glad I did go on it. I had to have a CT scan after the trials, and they found that I had something wrong with me. What they did was scan your lower limbs, and then somebody spotted after they checked the scan that they saw the cancer. They just found it. They wasn't looking for it at all. Somebody spotted it. That's when they contacted me. If I hadn't have gone on those trials, I would have never known, because I had no symptoms and nothing. I wasn't feeling ill. I was still eating and doing the usual what I normally do. So I'm very, very glad I went on it. It's meant a lot to me, because I wouldn't be here today. I wouldn't be here today if I hadn't have gone on that trials, because I would have never known. So I'm grateful that I went on it. I have got a lot of friends, so I'm not like lonely on my own. I find things to do every day.
My health issues really began when I contracted polio. I made a decision that I was far more independent in a wheelchair than I was on a pair of calipers, because I didn't like the way I walked. I didn't like the way I looked. So it hurt me so much to walk, particularly on my back. When I was in my 20s, early 30s, I began having problems with my liver. I was approached about doing research regarding diabetes. I said, of course I don't mind helping. On a regular basis, they were taking readings, more scans, to see if there was any changes. They gave a fantastic report, really, really informative. Patients learn a lot more that way, because quite often consultants don't have the time to sit and explain, because you're only allocated 10 minutes per patient or whatever. But when studies are done, they're priceless, and they should be valued, because they really teach you as an individual. I've learned a lot more about polio because of research, and I've certainly learned more about my liver and my diabetes.
Really, the best way of receiving medical treatment is to be part of research. So when it's absolutely life and death, if we look at childhood cancer, children who get cancer, for the most part in the UK, almost all of them will be enrolled in a clinical trial, a huge number of them. And because we've been doing that for many years, we've seen death rates from children with cancer just plummet. I mean, conditions that were all but incurable are now, the majority of children will survive. Being involved in research is absolutely the best way of getting the best treatment. It extracts the best from everyone who's treating you, because there are all kinds of other details you have to pay attention to if you're in a research study. But it also helps the people who come after you.
I think the problem with trust at the moment is we have a long history of trust being violated with specific groups over and over and over again. So I think that to overcome that, actually, you have to proactively build.
We are all part of the same community. And so now is the time to really think through this, deconstruct older systems, flattening the hierarchy, listening to people. We've heard so much about the importance of just listening. People from healthcare just need to kind of be quiet, listen, understand, be open-minded. Think about how we rewrite some of our processes based in excellent science.
There is no way we're going to be able to build the bridges we need to build to dive deep into the communities that are currently underserved without the public and patients, all of us getting involved.
If we are to make progress that benefits everyone, is for everyone to become involved in clinical research. Whether they are conducting the research or whether they are the subject of the research, everyone must become involved. And so I would plead with anyone who feels that they have been outside of this to try and explore coming within, because that will just make life better for everyone.
For me, the utopia is that research is in the very fabric of the healthcare system. Research could be as simple as taking part in a questionnaire, giving a blood sample. Some research is more time-consuming, but give it a chance, give it an opportunity to hear about what might be involved, how you can contribute to the research in however form you want.
We should love you to get involved in clinical research, because by doing so, you can help shape the future for hundreds and thousands of patients in this country and across the world, by helping to improve health outcomes for everyone in the future.
Give it a shot, give it a chance, and see where it takes you.